hyponatremia. So I'll just give a brief introduction. This was a 71-year-old male who'd quite recently retired from the hospitality industry. He worked in the sort of supply and provision of fine wines for city events. And he'd been feeling unwell for 3 months, and first noticed it when he was on one of his walking holidays. He planned many of these for his retirement. And he'd gone to see the GP. He'd started him on a course of antibiotics for possible sinusitis. And then in the routine workup, the GP noticed that the sodium was 122, and so called the patient and asked him to immediately attend the ED and see the medics. So when I took a history from him, his main concern was actually one of breathlessness. I think this was January, so a couple of months ago. And since November, he'd noticed that when he was hill walking with his wife, he was finding it much harder to actually complete the walks that they'd planned. He'd have to take far more regular breaks. Toward the end of November, he tested positive for COVID, but didn't have a cough and didn't have fever. And then the ongoing symptoms of sort of lethargy and exertional breathlessness were attributed by him and his wife to a possible case of long COVID. And he says that usually around this time of year, he comes down with some colds and gets runny nose. And I think the sort of kind of coryzal story is what led the GP to consider some antibiotic sinusitis, because I think by the time he went to the GP, he'd been having these symptoms for quite a few weeks. He also reported that in the 7 days prior to his attendance at the ED, he'd been having these nosebleeds, which was unusual for him. He denied any symptoms of paroxysmal nocturnal dyspnea. He was able to lie flat, wasn't needing any extra pillows, hadn't had any chest pain that was cardiac sounding in the past 6 months. He didn't have a cough with a shortness of breath. He hadn't really had weight loss. He denied, I unfortunately can't see what I've actually put on the right. I think he denied night sweats and fevers, no changes in bowel habits, no changes in his vision, no headache or weakness or numbness in his arms and legs.
Is that you can't see it because the your viewing thing is? You can...
I have a laser pointer open, so I have to go back to my mouse to move the chat away. So maybe I'll just stick to the mouse rather than the laser pointer. There we go. Now I can move things again.
Yeah. Okay.
That's better. His past medical history included asthma, eczema. He was on a statin for cholesterol, and he was a bit overweight, but he was quite tall. He was certainly over 6 foot, and on the sort of overweight to scale, but he was fit and well enough to do lots of hill walking. I think they had a holiday home, perhaps just in Spain, and they did lots of hill walking. And his drugs was just statin and salbutamol. Had a family history of bowel cancer on one side and ischemic heart disease on the other. But the heart attack wasn't at a young age. It was very much in the sort of 60s or 70s. Socially, he was a daily wine drinker, which would be completely in keeping with the job that he had and was quite successful in. And he had a 20-pack year history much earlier in life, but hadn't smoked at all since his mid-30s. On examination, he was sat at the bedside. His wife was with him, and they were both sort of chatting to me and giving me the history of what had been going on. He looks a bit pale, and he mobilized a bit laboriously. He looked actually a bit sweaty, and his peripheries were warm, clammy to palpation. He didn't have any edema and didn't have any lymphadenopathy. Normal heart sounds, regular heart rate, blood pressure in normal range, was not pyrexic. His chest was completely clear. And his abdomen was soft and non-tender, normal bowel sounds. I actually did a PR later on, and that was also unremarkable. Normal feeling prostate. He was clinically euvolemic, and that's in the context of the fact that he was referred with a sodium of 122. It's chest X-ray. I'll let everyone have a look, but I
you want to comment on that chest X-ray? No one's going to comment.
No. So I felt there was no, there were no effusions, there was no consolidation. The high-low were a bit prominent, perhaps, and I don't know what this little thing on the bottom right corner was. I think this history that he had of, many months of sort of non-specific lethargy and this low sodium that had come in and the euvolemic state. At this point of the assessment, I was kind of looking for any evidence of cancer somewhere.
Adam's going to put his hand up.
So I was going to say, there are a few nodules. I can't really see, it's quite blurry. There's about 4 or 5 nodules in the lower zones.
Do you think these ones here? Or,
and then there's one on the left under the heart shadow, I think. I can't tell, the resolution's quite bad on my screen.
Yeah, agree.
Yeah.
And also the right lung, there's about 4 or 5, sort of a bit more medial to your arrow.
Yeah.
I can see what you're talking about. And quite often I think radiologists say, oh, that's just a vessel end on. But I agree, it looks a little bit sharper edged, doesn't it?
Yeah. So I was a little bit concerned about these sort of little round things and perhaps something down there. But the things that you're pointing out are far more obvious.
Okay.
ECG, quite unremarkable. It's normal sinus rhythm, normal axis, narrow QRS, good R wave progression.
Yeah, R wave, yeah.
And these are the blood tests that I had when I saw him.
Okay.
So his hemoglobin was low, which I guess he looked a bit pale, and it was really low, 70. But his hematocrit seemed oddly dilute, I guess. Sodium was 121, just like in keeping with what the GP had reported. His adjusted calcium was a little low. And his albumin was 22, but his protein was 127, which is the highest value I've ever come across. The CRP was normal. So I'll just wait for a couple of seconds before switching across.
In the chat, any thoughts about that sky-high total protein?
I can't put anything in the chat, but you always think of myeloma, don't you, with a high protein?
Yeah.
Adam's put paraproteinemia.
Yeah.
Indeed. And the calcium is a bit tricky because although that's adjusted, when you've got such a low albumin, the total calcium must be really low.
Yeah.
Okay.
Exactly. So I included that in my workup. So I sent off a myeloma screen and immunoglobulins, and I also at that point sent off just kind of work up what was this, because this low sodium was below 125. It's very severe. He didn't seem symptomatic with it, and Amina's just suggested, could that be pseudo hyponatremia if the protein's that high? And yeah, this was something that we were thinking. So all of those things we've just discussed. The 71-year-old male, high cholesterol, on statin with asthma, eczema, presented with shortness of breath, hyponatremia, high total protein, possible pseudo hyponatremia, and possibly myeloma.
Yeah.
So this was his hyponatremia workup. And if we bring up a 5-option screen, Prof, yeah, looking at these results, what would they be consistent with?
Okay, so let's just read them all out while people are thinking. Yeah, we've got a serum osmo that's high, a urine osmo that's 375, and you'll never see a reference range for urine osmo because, of course, the reference range for urine osmo is 40 to 1000, because if you drink lots of water, it's 40, and if you're dehydrated, it's 1000. So that has got to be interpreted in the light of the patient's hydration and their sodium and osmolality. Okay, and then you've got a urine sodium that's 46, and it's just probably worth saying that a urine sodium of less than 20 means you're dehydrated. So if you're more than 20, then that means you're well hydrated or normally hydrated. Okay, and then everything else looks okay. Let's get the total protein. Okay, so I can see, because I can see the votes coming in, that only one of the 27 people on the call has voted so far. So come on, everybody else. We need 27 votes. It's easy to do, just click on it.
Completely anonymous.
It is completely anonymous, that's right. So the options are SIADH, hypothyroidism, pseudohyponatremia, nephrotic syndrome, and is on like diuretic.
So most people have gone for A, which would be SIADH, and a third have gone for pseudohyponatremia. So that's good.
Yes, it's worth saying one of the problems with the multiple choices is that, and especially with a low sodium that's low, you might have more than one cause. Okay, it's worth just telling everybody that.
With an osmolality that's normal or high in the context of a sodium that's as low as 121, something should be fishy. It's something unusual. It's an unexpected result. There's clearly been a kind of artifactual contribution perhaps to that result. And so the answer would be a pseudo hyponatremia. And we can talk a little bit about why that is. So I remember this case, the following day was taken over by Patrick, one of the ACCS trainees, and he sent me a really great biochemistry PDF. That was, I think it was, I can't remember how you titled it, but it was just the whole, it was the renal cheat book, he titled it. And if you think about how we calculate osmolality, it's the sum of 2 times the molar concentration of sodium plus the molar concentration of urea and the molar concentration of glucose. And sodium is the biggest contributor to this value whenever you calculate it numerically. So if sodium goes down, particularly down to 121, you would expect osmolality to decrease. If osmolality has not decreased and is in fact elevated, then there's something unusual with the results. So the osmolality, when that's low, it always equals hyponatremia. When someone is hyponatremic on a blood test, it usually equals, you usually would see a reduced serum osmolality. And in this case, the osmolality is elevated. So something is amiss. Yeah, no, so if you look at just the osmolality and the sodium, you think there's perhaps SIADH and he was eulemic earlier in the examination. But the key thing is that before thinking, is this SIADH? And I didn't appreciate this as a medical student or as a foundation doctor, to be honest, until I came across this case, that surely there's not going to be somebody who's going to come in with, pseudo hyponatremia. But really what we're looking at when we're looking at a sodium value in a laboratory is an experiment. It's a laboratory experiment that may have been done billions of times, but it's nonetheless just an experiment. And all experiments are liable to all sorts of artifactual factors that can make them not real. So the thing that made me lose sleep when I was doing research is the work that I've been doing for the past 3 years. Is it all completely, nonsense due to some unthought of artifact in the experiment and the way I'm doing it, or the way someone else did it before me, that kind of thing.
Yeah. And
when we're calculating the concentration of sodium, so when someone is hyponatremic, we're worried about that, because if the osmolality of the water component of the blood is low, there'll be water shifts from the cellular space into the serum, and in the brain that's problematic. So what we're interested in is osmolality and the concentration of sodium specifically in water, and that's what we think we're looking at when we see the results. Whereas in actual fact, what we're looking at is the concentration of sodium in all of the plasma volume. So we take those yellow bottles that have that gel that make the blood clot, they spin it all down in the lab and they calculate the concentration of sodium in the complete volume of the kind of translucent yellowy component after they've spun it down in the lab. Whereas in actual fact, what we want to know is what the concentration of sodium is in the water. If you've got an excessive quantity of lipid, and I find the lipids easier to remember because when everyone who washes a frying pan sees the lipid droplets separating from the water and creating their own volume and space, you're going to increase the total plasma volume. And so the concentration of sodium in water is going to go down, but the osmolality of water hasn't necessarily gone down. And so it might not, so it's a pseudo low sodium. It's a low sodium because the lab machines are calculating sodium as a component of the entire kind of yellowy translucent fluid that they're taking out from the top of that serum tube. And so when we look at low sodium, the serum osmolality is really important, because that tells us right there whether this could be complete nonsense as a result of something else that's going on. Because sometimes you have to specifically request total protein or lipids. In fact, often you have to request protein or lipids alongside it, and that's why it always forms part of the bundle of tests that people request over the telephone, or that you find in sort of the Oxford handbook. Send off the protein, send off the lipids, send off the glucose, all the factors that could leads to the ultimate value of the sodium being potentially not that relevant to the clinical case that you're looking at. And I found that diagram really, really helpful actually from that PDF. And I've taken this from there was a page that I met I found really helpful just in the normal Oxford Handbook of Clinical Medicine and how to approach hyponatremia. And I think the first thing, send off that serum osmolality. Is it true hyponatremia or is it not true hyponatremia? Send off the things that will enable you to interpret that serum sodium, so the proteins, the lipids, the glucose. Because you're taking blood samples, you can also send off cortisol and TFT, so we're looking for Addison's and hypothyroidism, which are two causes of true hyponatremia. And examine the patient alongside sending off these tests. Are they euvolemic, dehydrated, edematous? If they're dehydrated, the history will tell you probably why they're dehydrated, and you can replace them with isotonic fluids, and then you monitor their sodium for an improvement. If they're euvolemic, we need to be thinking, is this SIADH? And we'll get the answer to that from the urine samples that we'll send off alongside the serum samples. And you fluid restrict if you have to. If they're edematous, then you need to work out why they're completely edematous. And usually when you treat the cause of the edema, the sodium itself, by getting rid of the excess water, will normalize to a normal value. And you want to correct the sodium slowly, so usually not more than, say, 8 millimoles a day or 10 millimoles over 24 hours. So if you are rehydrating them, if this is a dehydration that's been going on for more than 2 days, it's at that point a chronic hyponatremia. And so we really, because it's difficult, often our patients are elderly and can't give clear histories, it's possibly safer to just kind of be a bit cautious unless the dehydration is a bigger risk to their clinical status there and then. You just keep testing and keep modifying your treatment in accordance with the increase in sodium. So back to our patient who has pseudohyponatremia and an anemia with a very high protein. Someone's already suggested that we send off tests to look for myeloma. So I can present these now. So the immunoglobulins showed that the IgA and IgG were normal. IgM was elevated. And looking at the light chains of the immunoglobulins, the kappa chains were particularly elevated, and the ratio of kappa chain to lambda chains were 2.1. So there's a disproportionate enrichment in one of these light chains. And looking at the serum protein electrophoresis, there was a discrete band in the gamma region, which was identified as a paraprotein. And so this isn't the electrophoresis of this patient, but it's possibly what it would have looked like. So you're just taking all the proteins in serum and you're just running them down a gel by using an electrical current, potential difference across the two ends of the gel, and they separate according to size. And albumin is usually supposed to be the most abundant protein in the blood. So a normal electrophoresis would have a peak in the albumin, and then it would be individual peaks in other proteins that we often test for, like transferrin. The gamma region is where all the immunoglobulins tend to appear, and when this is elevated, it's because it's clearly an abundance of immunoglobulin itself. And the light chains being a 2-to-1 ratio between kappa and lambda, ultimately, irrespective of what immunoglobulin you're looking at in the blood, they randomly will either contain kappa or lambda. The class of immunoglobulin is entirely determined by this heavy chain. The light chains randomly associate with these heavy chains to form a complete immunoglobulin. There should be a ratio of 1-to-1 in an inflammatory state. If immunoglobulins are elevated, you shouldn't expect to see lots more kappa than lambda or lots more lambda than kappa. So when there's an enormous skew to one side, we're thinking that there's clearly some overproduction of a specific immunoglobulin that's taking place, perhaps. And immunoglobulins are made by plasma cells that differentiate from B cells. And in health, that's only when they've encountered an antigen. But in disease, like myeloma, which affects plasma cells, you'll then get a single plasma cell clone which expands out and produces vast quantities of a single antibody. So because the class of antibody that was elevated was IgM, and because the protein was really, really elevated, there were concern about hyperviscosity. and a diagnosis potentially of Waldenstrom's macroglobulinemia. So the team on Marjorie Warren were liaising with the hematologists as these tests were all coming in, and the patient was really promptly transferred to Hammersmith. And Waldenstrom's macroglobulinemia, I remember, was disproportionately overrepresented in all of the question banks I did before, well, the single question bank I sat before sitting MRCP, like part 1. There were just so many. This came up so many times, and for a condition that I've now found is 1 to 4 per million of a population. But I guess it's that they bring it up because of the syndrome of hyperviscosity, and it's something that we need to be looking out for when we're clerking in patients with really high protein levels and suspicions of myeloma and who are having nosebleeds. So it's a B-cell malignancy. So it's an overexpansion of cells in this part of the hematopoietic tree. When you look at it under the microscope of the bone marrow, you've got a spectrum of differentiation from these immature, naive B cells into these antibody-producing factories, plasma cells. So IgM-producing cells, and more than 90% of cases are due to a mutation in a protein that's involved in signaling downstream of cytokine receptors and other classes of innate immune receptors. And if you look at, so I got this from a different paper, if you look at the bone marrow film, it's going to be infiltrated with large numbers of these lymphocytes with large nuclei. And some of these lymphocytes will just look like normal naive B cells, so very little cytoplasm, mostly nucleus. Others will look like plasma cytic cells, sort of an intermediate state between the B cell and the plasma cell. And there'll be plasma cells that also look a bit enlarged and atypical. And the plasma cells tend to have more cytoplasm because they usually need to pump out. Their entire reason for existing is to produce antibodies. And so that cytosol is all designed to kind of synthesize as much of it as possible. So lots of ribosomes. And hyperviscosity syndrome is a consequence of having a very abnormally large quantity of the IgM paraprotein in the blood. And so which of the following are features of the hyperviscosity syndrome? All of the above, yeah. And this was something that I didn't think of when I was clerking the patient. I asked about headaches and eye symptoms. I didn't realize nosebleeds or bleeding, because in my mind, it was hyperviscosity. It would just be lots of clots forming. So I was mainly in the back of my mind thinking of things like sinus thrombosis, that kind of thing.
I mean, this patient had nosebleeds, you mentioned, but that is the clotting affected by, not by the viscosity, but by the hematological problem?
Yeah, so, well, I looked this up. I didn't read the papers, but just the reason, the things that had been cited were the actual paraprotein itself, the IgM, can interfere with the coagulation cascade. It's, right. And in particular, von Willebrand's factor. You can end up with an acquired deficiency in von Willebrand's factor. And that's one of the reasons that's been touted, one of the reasons why that's been touted for the bleeds. Other things, they say there are increased shear forces on the vessels because of the hyperviscosity, and so they may be more prone to rupturing. And he had been having nosebleeds, and that at that point, I think, looking back on the case, should have prompted maybe a discussion with hematology earlier on, and he ended up being transferred over relatively quickly, but he then had a nosebleed, as I'll go into later, when he got to the Hammersmith, and then lots of things happened very quickly. And the diarrhea, they can get malabsorption, because whenever you've got excesses of protein, it can just deposit in places, and you can end up with a malabsorption type syndrome if the plasma cells, particularly in the lamina propria of the gut, are producing lots of antibodies, because they can infiltrate various organs, not just the bone marrow and peripheral neuropathy. It's almost like an amyloid type syndrome. You can end up with vasculitic pictures, sort of cryoglobulinic rashes. So all of the above and more. And the clinical triad is eye signs, neurological signs, and epistaxis, hearing loss. And this is a picture of a retinal hemorrhages that you can find in these patients. I didn't look in his eye either. So, like I said, bleeding could be caused by interference of the paraprotein with the actual coagulation process in itself. Apparently, there are abnormalities in the thrombin time itself if you test for it in some of these patients. And looking at his protein levels on the graph, so he came into hospital, he was seen, he said that he'd had some intermittent nosebleeds in the preceding week. He then, once all the tests came in, he was transferred over to the Hammersmith Hospital. Within a day of being there, he then actually had a nosebleed, and he was seen on the ward round, and within that same day, that was then classified as a sort of hyperviscosity emergency, and so they arranged an emergency plasma exchange and cyclophosphamide. I think this is quite good. He basically came in, and within a day, he then, within 48 hours or 72 hours, he was given definitive treatment. But perhaps that might have happened earlier if the nosebleeds were emphasized as a more, I thought nothing of the nosebleeds. And the plasma exchange obviously brought the protein right down. That then came straight back up, and he was given a dose of rituximab and chemotherapy, which would have targeted a wide variety of B cells and those intermediate plasmacytic cells, and that's progressively improved over time. I guess the key things to take away is always test for pseudohyponatremia, because what we're looking at is an experiment, and that's always prone to artifacts, and so we can test for the artifacts. So rule those things out and then interpret them. Sodium, really high protein levels, think of hyperviscosity and look for myeloma. And hyperviscosity is not just about clotting, it's also about bleeding. And the osmolalities are really difficult to get done. So for this particular patient, those results took days to come back. And they were sent, if they just all get done in batches, and they do them by hand, I'm told. So if you want to get the result back quickly, you just need to tell them that you're going to be running it to them, and then, or someone's going to be running it to them, and then they'll do them on the day. It would influence management in some cases. So thank you everyone for listening and contributing.